Hello everyone, welcome to our new How Do I episode in English. Today we will talk about the new World Health Organization classification of pituitary tumors. It is my great honor to introduce our guest, Associate Professor Olivera Casar-Borota, a neuropathologist at Uppsala University Hospital. Professor, welcome. It is a privilege to have you here today.
Thank you so much. Thank you, Mirjana and the colleagues, for inviting me. It's my pleasure to be here and to answer your questions. Please.
Thank you for accepting our invitation. So we can begin with our first question for you. Professor, can you tell us how does the change in nomenclature from pituitary adenoma to pituitary neuroendocrine tumor affect histopathological diagnosis and our clinical perception of the tumor biological behavior?
Well, criticism of the previous terminology and classification was mainly focused on the simplistic distinction between pituitary adenoma and carcinoma, based solely on metastatic spread and not reflecting the entire clinical spectrum in terms of tumor invasiveness, metabolic disorders, response to treatment, and so on. So I would say that clinical implications of PiNET terminology are, from clinical point of view, increased understanding of the tumor biology and recognition of the spectrum of the clinical behaviors. From histopathological point, improved tumor characterization and assessment of the prognostic tissue markers. And finally, from the point of research, I think that PiNET terminology has encouraged a translational research that will hopefully ultimately lead to development of a prognostic integrated clinical, histological, molecular classification of pituitary tumors. So, back to you.
Thank you. The second question is, what is the role of immunohistochemical detection of transcription factors PIT1, SF1, TPIT in the WHO classification? What do they enable compared with the earlier classification based solely on hormone expression? Are there types of pituitary tumors that are clearly defined or better recognized in the newer WHO classification?
So, immunohistochemistry for pituitary specific transcription factors has definitely refined PiNET classification. It has first enabled a more precise classification of hormone-negative, non-functioning pituitary tumors that were previously designated as null cell adenomas. And I will illustrate that in these three specimens from non-functioning pituitary tumors, all three with similar morphology, with none or only sparse hormone expression, and only thanks to immunohistochemistry for transcription factors, we can classify this one as silent gonadotroph tumor, this one as corticotroph, and this one as PIT1 positive tumor, or in this case, lactotroph tumor. And this is maybe especially important for the diagnostics of non-functioning corticotroph tumors that may be potentially more aggressive than other subtypes. So, addition of the transcription factor to the diagnostic immunohistochemical panel has dramatically decreased proportion of null cell adenomas to less than 1%, even 0% in this Australian study. And recent molecular studies, as this transcriptomic RNA study, also support cell lineage-based pituitary tumor classification according to the transcription factors. And interestingly, as we can see here, these two black squares represent null cell adenomas, and they cluster either as corticotroph or gonadotroph tumors. And also in this study by NEO, these dark blue rectangles are null cell adenomas, and they cluster together with some SF1 positive gonadotroph tumors. And this is not only academic, this changes also our diagnostic approach to hormone negative, transcription negative pituitary neuroendocrine tumors. Today, we recommend an extended immunohistochemical panel with several organ-specific markers to exclude a cellular metastasis of NET from other organs, molecular diagnostic with, for instance, epic genome-wide methylation analysis may be helpful, and also imaging workup with gallium dotatoc PET, for instance, should be considered in the multidisciplinary team in order to exclude neuroendocrine tumors in other locations. And in addition to silent corticotroph tumors, in addition to null cell adenomas, another tumor type that is better categorized in the current classification is plurihormonal PIT1 tumor, with its two subtypes: mature plurihormonal PIT1 tumor with typical morphology, extensive expression of growth hormone prolactin TSH, and immature plurihormonal PIT1 with a less differentiated morphology, only patchy expression of PIT1 lineage hormones, and it is especially important to diagnose because it is considered as potentially more aggressive of these two subtypes. So, back to you.
Thank you, Professor. And can you explain us which histopathological features are currently used to assess the aggressive potential of pituitary tumors, and how have their interpretation changed compared with older classifications?
Well, we have unfortunately no histopathological markers that can reliably predict aggressiveness in pituitary tumors. If we look at cell atypia, which is a classical histological marker associated with aggressive tumor, it greatly varies in aggressive pituitary tumor from slight to pronounced, and as in these three cases of aggressive pituitary tumors. And we have possibility to study morphological features of 38 aggressive pituitary tumors, and in the first surgery specimens, we found almost equal proportion of tumors with slight atypia, moderate atypia, and strong atypia. If we look at cell proliferation assessed by mitotic count and Ki67 proliferation index, we see that cell proliferation also can greatly vary among aggressive pituitary tumors. And as in these three cases, one with no mitosis and only a few Ki67 positive cells, another one with scattered mitosis and slightly to moderately increased Ki67, and third one with many mitoses and very high Ki67. And again, in our cohort of first surgery specimens, 38 patients with aggressive pituitary tumors, only a proportion of cases had significantly increased mitotic activity and Ki67 above 10%. And that is the reason why mitosis and Ki67 should be reported, but they are not included as grading criteria in WHO classification.
Thank you. Is there a place for molecular biology in the diagnostics of pituitary tumors?
Thank you for this question, my favorite. Yes, definitely, there is a place for molecular biology in the diagnostics of pituitary tumors, and I'm sure that molecular pathology will take even more place in the future when we deal with pituitary tumors. And I would say there are two situations when we need molecular biology in PiNET diagnostics. One situation is when we suspect an aggressive pituitary tumor. Then we can get help of molecular biology to identify molecular markers associated with aggressiveness. And I will mention a few of them. TP53 first, gene variants are probably the most common pathogenic alterations in aggressive pituitary tumors. Problem with TP53 in routine diagnostic work is that immunohistochemical protein expression of P53 does not always correspond to TP53 gene mutational status, as shown in these three cases of aggressive pituitary tumors. The first one, TP53 wild type with a few positive cells. Another one, TP53 mutated carcinoma with a clear overexpression of P53 protein. And the third one, again, TP53 mutated, however, with not a single positive cells. And it is one limitation factor which indicates that if we suspect aggressive pituitary tumor, then we need to perform one sort of TP53 sequencing analysis if we want to reliably assess mutational status of TP53 gene. Another molecular marker associated with aggressiveness of PiNETs is ATRX. We have previously demonstrated intact, preserved, normal ATRX immunolabeling in a large cohort of benign pituitary tumors. However, one of two carcinomas, a corticotroph carcinoma in a female patient, lacked immunohistochemistry of ATRX in tumor cells. You see here normal expression in endothelial cells and maybe some fibroblasts, but tumor cells are negative. And this lack of immunolabeling was caused by a large deletion of ATRX gene from exon 3 to almost exon 30 of 36 exons. So after that, we validated these results in a larger cohort of 48 patients with aggressive tumors. And we have also today other studies that confirm strong association between ATRX alterations and aggressive or metastatic phenotype in pituitary tumors. In our study, about 20% of all aggressive tumor and almost 30% of carcinomas had ATRX alterations. ATRX alterations are mostly present in corticotroph tumors, but can occasionally be found in other types. ATRX mutations are an early marker predicting aggressive potential already in the first surgery specimens. And in patients who maybe developed aggressive phenotype several years after the tumor diagnosis and first surgery. ATRX alterations can vary. It can be variants, gene variants, or large homogeneous deletions. It is interesting that ATRX alteration frequently coexist with TP53 variants. And in contrast to P53, there is a good correlation between lack of immunohistochemical ATRX immunolabeling and loss of function ATRX gene mutations. Then the third marker is SF3B1, a marker of aggressiveness in lactotroph tumors. Still, unfortunately, majority of aggressive and metastatic pituitary tumors are without known gene alterations, but it is very intensive research in this area, so I hope we will soon have additional molecular markers of aggressiveness in PiNETs. So the first indication for molecular biology is identification of molecular markers of aggressiveness. Another one situation is when dealing with low differentiated cellular tumors and so-called null cell tumors. In this situation, we can actually get help of methylation analysis, epic methylation analysis, which can classify pituitary tumor as pituitary tumor, even if immunohistochemistry for hormones and transcription factors is negative. And as you can see here in Heidelberg classifier of central nervous system tumors, if we focus on this corner here, you can see that all main types of pituitary tumors are included: somatotroph, sparsely granulated, densely granulated, pterotroph, corticotroph, all types. However, epic methylation analysis is not yet prognostic, but we have studies as this one, where we studied methylation profile in 64 patients with aggressive pituitary tumors, including 16 patients with carcinomas and 12 benign control specimens, and we could demonstrate separate clustering of benign tumors from aggressive and metastatic pituitary tumors. And interestingly, when we studied specimens from the first surgery, 3 clusters could be demonstrated: pituitary carcinomas, aggressive pituitary tumors, and benign tumors. So I hope in the future genome-wide methylation analysis may provide a potential tool for early identification of aggressive and or metastatic pituitary tumors.
Thank you. And which information in the current histopathological report of pituitary tumor is crucial for today's clinician, and which was previously unavailable or insufficiently used?
Histopathological tumor type is important, of course, especially recognition of potentially more aggressive subtypes as silent corticotroph tumors, immature plurihormonal PIT1 tumor, Krug cell tumor, sparsely granulated somatotroph tumor, and so on. Then I would underline that we need a really critical approach to the uncommon null cell PiNET, which may require an extended diagnostic workup. Then for endocrinologists, it is important to take into consideration a combination of prognostic factors: mitosis, Ki67, P53 expression, MRI evidence of tumor invasiveness. These prognostic factors have a stronger significance in combination than in isolation, as proposed also by Professor Trilla in her classification. So take into consideration combination of these factors. And finally, consider molecular genetic analysis when an APT is suspected.
Thank you. And the last question: do pathologists participate in the multidisciplinary pituitary conferences at your hospital?
Yes. In Uppsala, we have a weekly multidisciplinary pituitary rounds and monthly, and pathologists participate in monthly conferences. We like it very much, we enjoy it, and I think it is the best, it is an excellent forum for multidisciplinary discussion of clinical, radiological, histopathological findings for improved diagnostics and optimal management of the patients with pituitary neuroendocrine tumors.
Great. Those would be all our questions. Thank you, Professor, for the excellent lecture.
Thank you so much for your invitation once again, and it was my pleasure. Thank you so much.
Thank you.
Thank you. Bye.
Bye. Bye.